All right, today we're putting on our detective hats to solve a classic diagnostic puzzle. We're going to start with a really common clinical scenario and follow the clues all the way to a very specific and pretty interesting diagnosis: canalicular adenoma.
So let's set the scene. You've got an older patient. They come in with a slow-growing, firm little lump on their upper lip. Pretty common, right? So what's running through your mind? What's at the top of that differential diagnosis list? That's the exact question we're going to dig into.
You know, with that location and history, your brain is probably already screaming salivary gland tumor, and you'd be on the right track. We're going to get super specific and dive deep into one in particular, the canalicular adenoma. Let's really break down what makes this thing tick.
Okay, so first things first, let's build out a patient profile. I mean, with any good investigation, you got to know the classic MO, right? Who gets this, and where does it almost always pop up?
And when we talk about where, well, there is one location that just completely dominates the picture. We're talking about a whopping 80%.
Of these tumors are found, you guessed it, right on the upper lip, just like in our case. This isn't just a common spot, it's the classic textbook location. It's a massive clinical clue you just can't ignore.
Okay, so that's the where. What about the who? Well, the data is pretty clear here. We're almost always looking at adults over the age of 50. In fact, it peaks in the 7th decade, so folks in their 60s.
So let's put it all together. We've got an older adult, upper lip mass. What's the last piece of the puzzle? Well, there's a really notable female predominance. So our classic patient, the one you should have in your mind's eye, is an older woman with a firm little lump on her upper lip. All right, so we've got the clinical picture locked down. Now let's take this investigation from the clinic and head over to the lab. It's time to get this thing under the microscope and see what clues the tissue itself is hiding. Okay, starting out on low power. The first thing that probably jumps out at you is that this is usually encapsulated. See how it has those nice, well-defined borders? And even from way out here, you can start to see these branching, channel-like or canalicular spaces. That's actually where it gets its name. Okay, let's zoom in for a closer look. As we do, the signature pattern that really defines this thing starts to come into focus. So what are we actually seeing here? Check out these beautiful, almost delicate, bilayered strands or ribbons. They're made of these really uniform, cuboidal-looking cells. And notice how they all connect and weave together. The fancy word is anastomos, to form those little channels, the canalicular spaces we talked about. All of this is sitting in a background, a stroma, that's pretty sparse but has lots of blood vessels. This whole pattern, this is the key to recognizing it. But here's where it gets really interesting. There's one feature that truly, absolutely sets this tumor apart from all its lookalikes. It's not about what's there, it's about what's missing. And that missing piece is the single most important clue you're going to get.
And here it is, the big reveal. Unlike so many other salivary gland tumors you'll see, a canalicular adenoma has absolutely no basal or myoepithelial layer. Zero. It's made up purely of these monotonous epithelial cells. And that absence, it isn't just some minor detail. It is the definitive diagnostic hallmark.
And this missing layer is precisely the key that unlocks the whole case, especially when you're trying to tell it apart from its number one mimic, the basal cell adenoma. Okay, putting them side by side like this makes it super clear, right? Look at the top line. That's the game changer. Myoepithelial layer, absent in canalicular, present in basal cell. End of story, almost, but there are other clues too. The cells in canalicular are monotonous and cuboidal. Basal cell has, well, more basaloid cells. The stroma is different too, loose and vascular in canalicular, more dense and collagenous in basal cell. And yeah, even the location is a big hint. Canalicular loves the upper lip, while basal cell adenoma is way more common in the parotid gland. So you might be thinking, how can I be 100% sure that layer is missing? Well, the proof is in the stains. We turn to immunohistochemistry. A canalicular adenoma will be completely negative for myoepithelial markers. The big ones you'd use are smooth muscle actin, or SMA, and calponin. If those stains come back blank, they don't light up, boom. You've just confirmed that crucial layer is missing. Okay, so let's put all the pieces of our investigation together. We've followed the trail of evidence all the way from the clinic to the microscope, and now I think we can confidently say, case closed. Let's recap the diagnostic hallmarks. Clinically, you're thinking of an older woman with a mass on her upper lip. Histologically, you're looking for those unmistakable bilayered ribbons making those canal-like spaces.
And the absolute clincher, the complete absence of a myoepithelial layer, which you prove with negative stains like SMA. You see all that? That's your canalicular adenoma.
So there you have it. We've solved our initial puzzle, but I want to leave you with one last thing to chew on. We know these tumors can sometimes be multifocal, meaning there can be more than one. So now that we know how to identify one so clearly, how does that little fact change how we think about surgical planning, or even long-term patient follow-up? It definitely adds another layer, doesn't it? Something to think about. Thanks for diving into this with me.